Oh, hey, Chris.
Hey, Chuck.
How are you?
I'm doing all right. It's a beautiful day in St. Louis, and of course, we're here inside. But I'm itching to get outside later on.
That is exactly right. I am going to be outside, enjoy it. I'm praying the cold weather does not really come back. And it's not super warm, but I'll take 50s any day.
But I'm a complete sucker. I will say, rule number one of having a Peloton is talking about the Peloton. It's like the opposite of Fight Club. There is a great live ride that I'm going to do later. It is the Bad Boy Entertainment Artist Series ride at
Oh,
12:30, and I'm gonna hop on that one. I can't resist. So even though I probably should exercise outside today, I will still ride my bike to nowhere.
so you are a hardcore Peloton, guy, and I'm a longtime owner, but recent conversion to the Peloton. I see the appeal now. I do. I'm starting to like it.
Well, I usually I think it's the I was before the pandemic, I was very much into going to like an interval running and training class before going to work. And obviously that changed with the pandemic. And I was kind of skeptical of whether I could really work out at home effectively. And I'm at the age where I need somebody to tell me what to do. And it works out pretty well that way.
That's
So it is nice to get it done in the morning, get it done early on the weekdays, and then on the weekends I try to do it a little bit later in the day to allow a little bit more rest.
like I said, I'm starting to see the appeal. I'm guessing your Bad Boys ride is too tough for me, so I'll
I don't
probably.
know about that. It's probably going to be pretty. It's going to be more a music based ride. By the time this drops, people probably have done it already. It's interesting on the hobbies during our fellowship interviews that we did recently. There were a number of people that that disclosed that they were big Pelotonites, which was really kind of fun. And I think one or two even put their leaderboard name on there, which is kind of gutsy.
Yeah, I would never.
Because I, you know what I did? I automatically went on and looked, and it was like, okay, all right, I see what we're dealing with.
That is fantastic. It really is remarkable the growth of that company and I mean that it was so positioned for the pandemic, and it is really interesting to see what the business world who has taken advantage, who was well positioned for the pandemic, and in healthcare too. And that's a whole nother episode. We could probably talk about that changes and what has worked and what hasn't worked, what'll stick. Really interesting to me.
Yeah, the serendipity of it is really interesting, and then also seeing how the holes in their supply chain. I think there's been a lot of. There'll probably be a very good business school, kind of case down the line. And unfortunately for them, I don't think they're going to be able to meet their demand in time, and people will probably end up looking elsewhere. That's a very crowded space now. So
But it does, and again, you correct me if I'm wrong, it does go back to their instructors in large part. I mean, they have a great platform, and they've done a lot of really wise things, but I understand their instructors have equity, and that's how they keep them, and I think that's a really big part of their success. So it'll be interesting to see if they can continue to grow.
well, just like people come to Wash U Hand Fellowship for people like you, I think people, it's the talent, it's the engagement, it's being able uh, to enjoy it, and like you said, like if they have skin in the game, you're gonna have more fun. So speaking of skin in the game, we love hearing from our listener community, and we got a great email from a fellow at UC Irvine. So this is from Connor Sullivan, and he had a question. And first off, he said he thanked us for the efforts with the podcast and said he's learned a ton. So thank you, Connor, and we appreciate you listening. And he had a question regarding one of Amy Moore's comments, using a nerve stimulator to jumpstart recovery. And he's seen this topic come up on the Doc Matter messaging boards, but never seen a protocol regarding how long, what setting, or even what to stimulate. Can you provide any insight? Now, I certainly can't speak for Amy, and I know that she had done some of this work. She continues to do this work in her lab, but has done some of it prior to leaving Washington University. And Susan McKinnon has done a lot of work in this area too. And there have been a couple of papers that have described their protocol in the lab. I am unaware of any protocols that have been described or published for human cases, but in the lab they would use a checkpoint stimulator, and they held that stimulator just proximal to the nerve graft site for 1 hour at a current of zero point 0.5 milliamps with a pulse width of 100 microseconds. And that was published in Grace Keene's study. Grace is a medical student who is, I believe, applying to plastic surgery residency this year. That was published in Hand in 2020. And also, one of our current residents in orthopedics, Sally Joe, had done some similar work with Susan in her lab when she was a medical student. They published that in Muscle and Nerve in 2019. We can include some PubMed IDs in the show notes if people want to look at that. But um, anecdotally, and I can't speak for Susan and Amy, I do recall Susan saying that, when doing this in cases, she will have an assistant, typically the medical student, hold the stimulator over over the nerve just proximal to the coaptation site for about half an hour. Now, that's obviously not a fun thing to do, and they have developed a jig to hold things in place so that somebody doesn't physically have to hold it. Um, but maybe at some point we'll ask for some clarification from Amy or Susan so we can share with everybody.
Yeah, and I hope you guys notice that usually Chris and I have a back and forth where I'll ask a question, he'll answer it. He asked the question, and thank you, Connor, we appreciate it. And he answered the question because he knew he couldn't ask me to comment. So that it was very well done. I love that.
I knew you were gonna roll your eyes, just like when I tweeted about sportsy injuries. Immediately caught backlash from you. So
So do me this favor, and I think hopefully the audience will appreciate this question because this actually is a question that came up twice in this past week, and I sent one patient to you, and I'm trying to send another patient to you that's work comp. Tell me how you think about a severe cubital tunnel syndrome, and when you think about quote unquote simply transposing the nerve, and when you might do more. So when you might add a distal ulnar tunnel decompression and when you might add a supercharged AIN transfer. So kind of talk me through that.
well, I think that the literature is certainly still, I think, hasn't settled on one answer yet. Susan has obviously done a lot of work in this area and has recently published a couple of reviews. I think one of our listeners and one of our friends, Holly Power, published with her and PRS recently on refining the indications for the supercharge. And I think that, Holly and Susan have this nice paper demonstrating the correlation between, clinical measures of strength in the ulnar intrinsics, such as pinch, and the motor amplitudes on a nerve study. And in the setting of severe cubital tunnel syndrome, the idea behind a supercharge would be to try and increase the number of functioning axons a little bit sooner and a little more distal, closer to target. And I like to use in the nerve conduction studies the CMAP amplitudes. And if there is a reasonable loss of CMAP amplitudes compared to the normal value for that muscle, it's different for the ADM and the FDI. Then I would consider adding the supercharged nerve transfer. If the motor amplitudes are close to normal, I don't think it's worth it, to be honest with you. And that, of course, is in the setting of, quote, active denervation that you see on the EMG part of the study with fibrillations and sharp waves in the ulnar innervated intrinsic muscles. Um, and then in terms of a Guillains Canal release, I think that even is still, up in the air. I don't know how you think about it. I'd love to hear your thoughts on that. But I tend to use, a direct compression, like a Durkin type maneuver, near the pisiform, kind of just into that zone one entry. And I'd like a Durkin over a Tenel because I think it's really hard to isolate the ulnar nerve when you're doing a Tenel because you end up percussing over the median nerve too. So if there is positive paresthesia in that area, I will typically add the Guillain Canal release. One could argue that really it's the motor component that's more important. So maybe the Durkin test isn't that reliable in that setting. But I think that most of the times, if I'm thinking about an advanced cubital tunnel patient, the CMAP amplitudes usually correlate with doing a supercharge, and obviously doing a Guillen's canal release is one of the steps of that supercharge transfer. So I've gone on long enough again about nerve. But Chuck, well, how do you think about assessing whether to perform a Guillain canal release?
I think your algorithm is really helpful, even for people like me who may not choose to supercharge, because I have the benefit of you being next door and I can send these patients to you. But just the way to think about this in a clean way makes a lot of sense to me. As far as Guillen's release or distal ulnar tunnel decompression, I also am skeptical of my ability to use a Tenels to gain much information, although I could convince myself it's helpful. I do agree with the Durkins or compression testing making some sense. I don't personally believe that a swollen, recovering nerve requires a distal decompression, especially at the distal ulnar tunnel, because I'm not sure I buy that there can be true compression there. So I hesitate to just add that in, although to be clear, occasionally I'll do it, but I don't decompress the distal ulnar tunnel very often.
And I think that another thing that if you're listening, you can use is potentially using your nerve conduction studies to evaluate, your latencies across Guillains Canal. But those are trickier in terms of when I've talked to our electrophysiologists, those are trickier to rely on, and oftentimes you will want to have the contralateral side. So whenever I order a nerve study and I'm suspicious for potential compression at Guillains Canal, I will ask them to do the opposite side ulnar latencies so that we can compare, because it's more the side to side comparison that's going to help you as opposed to the absolute value. And that's because of some of the technical factors that come in with how they do that study.
And you have been an earlier advocate and convert to the use of ultrasound. And again, that patient I sent you earlier or referred to you earlier this week was really interesting. It was in the setting of a previous ulnar nerve transposition and improvement, but not resolution. And the nerve studies were a bit telling, but the ultrasound was much more helpful. Where, as I recall, the diameter of the nerve was about 16 millimeters. Greater than 10 at our institution is considered enlarged, and I think it was 8 on the other side or something like that. That was really compelling evidence to suggest that a revision of some sort would be helpful.
Yeah, I think that's interesting. I remember pulling up that email, and I actually ended up talking to our resident on the service right now, Tom Hong, about that. And I don't know how, I think at some point we'll do this study, but we really don't know what the natural history, so to say, of the swelling in the ulnar nerve is after a transposition. So I'll be honest with you, it could be that that's just what ulnar nerves look like after you've manipulated them enough in order to transpose them. Now, obviously, all of this comes in with the clinical correlate of if there is a lot of tenderness over the transposed nerve and there are signs of it being potentially kinked at different areas and continued swelling, et cetera, that needs to be kept in mind. But we really don't know what an ulnar nerve looks like on an ultrasound after transposition. So I think at some point we'll probably end up looking at our ulnar nerve patients who are doing well after a transposition and potentially ultrasounding them. I probably shouldn't give away the whole study because somebody might beat me to it, but honestly, if somebody does it, that would be great. Or if somebody wants to work together on it, that'd be even better. Before we jump into the topic, I actually had one question technically about your Guillains Canal or distal ulnar tunnel decompression. I remember when I was your fellow, you kept the incision within the palm and didn't cross the wrist crease. And then when I went out into practice, based on some of the influence I had from Susan, I did cross the wrist crease routinely. But now I'm starting to rethink that because I think that wrist crease, even when you do a very nice and intentional zigzag Bruner kind of thing, that incision, that point really hurts people and can also scar in a way that is not only unsightly, but can lead to some limited motion. So, what are your thoughts about that?
It's an interesting question, and I have to say, I really continue to try to keep my incision distal to the wrist crease because it doesn't matter what I do and how I try to handle that zigzag. Inevitably, that's the complaint. The patient hates it, or I should say, most patients hate it. If I believe I can decompress well into the forearm safely, deep and on the radial side of the FCU tendon, and that may require releasing some of the superficial non-critical fibers of the FCU, then I absolutely keep my incision short. I'll occasionally go proximal to the wrist crease if I think I have to. And then the fun part, of course, is tracing the motor branch and watching it travel, heading ulnarly, heading distally, heading in the piezohamate hiatus. That's the fun part. But the key part, I think, for patient satisfaction is that wrist crease and keeping it safe.
Yeah, and there are times where I'm doing a combined carpal and guion, and I typically will place the incision kind of halfway between where I would for an isolated of each of those. And I don't know how you do it, but I typically tell it's a good lesson because I tell the trainee, I was like, okay, so I like to start with the carpal tunnel, and you'll basically shift the skin window after making the incision, and it'll be like you're learning how to recover from a too ulnarly emplaced ulnarly placed carpal tunnel incision. But once I've released the carpal tunnel and transverse carpal ligament, obviously that's the floor of Guillains Canal, and I use that as a guide to walk in, as opposed to digging through all the fat. If you were to start proximal to distal, if you were in the palm only, and I think that's really helpful. And then from that view, I do think you can get a safe release of that, entryway into Guillains Canal, kind of that pre-zone one tight fascia. And I think Susan's talked about that a fair bit as being a compressive point, but I do think that's important to release. And if I can get it without crossing the wrist crease, fantastic.
So I hate to ask a follow-up question because that means we're continuing to talk nerve, but I have to. So, I almost never perform a carpal tunnel release and distal ulnar tunnel decompression, even if I feel like there may be some small component of distal ulnar tunnel compression. I don't do that because the literature is clear. When you release the carpal tunnel, you change the configuration, the shape of the distal ulnar tunnel, and it effectively decompresses it. One of the studies I did early on, actually looking at the CMC joint and the need to how do you effectively deal with the CMC joint and what's the role of carpal tunnel release. It was an MRI study, and it echoed the data that's been previously published about the change in shape of the distal ulnar tunnel after carpal tunnel release. So I'm raising this issue because we do have trainees that listen. When does Chris D consider both a carpal tunnel release and a distal ulnar tunnel decompression?
I'd say the only time that I'm doing that is in the setting of probably an ulnar nerve transposition for the patient that doesn't have substantial enough CMAP loss or advanced denervation for me to consider a supercharge, but there is still some loss there. And they happen to have carpal tunnel symptoms as well. And they do have a positive Durkin's test at the entryway to Guillains Canal. I will decompress it then. And it's not for zone 1 and zone 3. It's for zone 2. I think 100% I agree with you that you will get an indirect decompression of zone 1 and zone 3, so the mixed and the sensory part respectively, with the carpal tunnel release. But I think if you're there to try and decompress zone 2, I don't think you decompress zone 2 with a carpal tunnel release because of the configuration of zone 2. It's a tight fascial band. Now, whether or not that's truly compressive is certainly up for debate, but I don't think that releasing the carpal tunnel will decompress that tight hypothenar fascia.
Love it, love it. Can I very briefly talk about a sportsy case, as you might
Oh
call
yeah,
it?
we have a case to discuss. That's right. I forgot. We're so into the nerve stuff.
Well, it's interesting because as I think I've clearly stated, sports is a big part of my practice. The other big part of my practice is peds and congenital. We haven't talked a lot about it. We probably should bring on a guest and talk about some congenital, not to bore people, because I know lots of people aren't interested, but there's some principles which I think are important that are hopefully interesting to everyone. So this case is a younger patient, and by younger, I mean less than 10, with a fall on an outstretched arm and elbow pain, and really delightful kid, really mature 8-year-old, and was seen by one of our partners and sent over with a radial head fracture with an X-ray and a CT scan showing a fragment from the radial head floating in the joint. And it's interesting when you reflect on when one reflects on one's career, what articles that you've written still resonate with you, and which ones you think are potentially most impactful. And I would say one of the smaller studies I've done that was the lead author was Nate Van Zeeland, who it was a resident at Vanderbilt, did our fellowship and now is in private practice. We combined some cases with my friend Don Bay in Boston and looked at these cases of skeletally immature patients who have essentially a Salter-Harris 3, or a growth plate fracture of the radial head. And if it's not identified, the radial head can subluxate or shift out of position, and arthritis can develop rapidly. So long story short, with this young patient, I did an elbow scope on an 8-year-old, and I've done young patients before. It does make you be even a little more careful than you usually would. Everything went great technically, and it was a fascinating fracture pattern around the radial head with a shear injury. Thankfully, the radiocapitellar joint was still aligned, but that's something I have to watch carefully. but it was a comminuted fracture of the head. And, we hesitate to do too much in the pediatric radial head fracture because permanent stiffness can result. And so we treated this pretty much arthroscopically. I was pretty happy with it, but it's a really challenging injury. And it made me reflect on that small manuscript we had written, which I think has stood the test of time. It's not really appreciated by many, the danger of that skeletally immature radial head fracture.
What's the best way for people to detect those? Is what's obviously you need to you need to have an index of suspicion. Is this something that is best assessed on a CT scan?
Yeah, it's actually my partner ordered the CT scan, and it was in this case helpful. I typically order MRIs, so that the starting point has to be an index of suspicion, where something doesn't quite look right in the ER or that first visit. And if you're careful, if pain is at the radiocapitellar joint and you carefully are assessing alignment, maybe there's something funny about the radial head. You have to think that maybe there's something more going on, and with the large cartilaginous component of the radial head, you have to have an index of suspicion. And my imaging of choice is the MRI. And if it shows a fracture, I think early intervention, potentially repair of the fracture, potentially imbrication of the radial collateral ligament, a component of the lateral ulnar collateral ligament, all of that's really important. I don't know that I have all the answers, but I know one thing, that if we miss this, you can't fix it. 6 weeks later, you can't fix it. So it's really interesting to me.
So was the fragment incarcerated in the radiocapitellar joint or the proximal radial ulnar joint?
It was incarcerated in or just posterior to the radiocapitellar joint. And it was largely this corticated bone, the little cartilage on top. And I actually brought one of my sports partners in, not that he had done this before, not that he even scopes elbows, but just to get a sense, is there any chance you think this would heal? And he didn't think so. I didn't think so. And so we did a microfracture of the central head where this defect had arisen. And the other fractures were well enough aligned that we decided to immobilize the child and give her a chance to heal on her own. I think she'll probably do okay, but I will keep a very close eye on things.
So you removed the fragment, made no attempt to fix the fragment because it probably wouldn't heal. Is that correct?
That's correct. And it was from the
Okay.
central radial head, which is a
Yeah.
really unusual position.
Yeah, that is weird. And of course, you managed to squeeze a microfracture in, so that's fantastic. Sportsy and or not congenital, but peds.
Yes.
That is perfect. That is perfect for you. And yeah, we should talk about congenital at some point. And I think there are probably going to be some very interesting topics that you could discuss, and even honestly, we could orient it towards families potentially too. There was one patient this week where I will admit this is a little ridiculous, but had a lot of questions about her Dupuytren's and wanted lots of answers. And I said, okay, that's fine. I gave her every answer I had, and she wanted to learn more. I said, okay, do you listen to podcasts? Can I borrow your phone? And I downloaded the episode for her because I've had other patients who have listened to some of the Thumb CMC episodes and brought it up. And I was like, you know what, maybe this will help, maybe it won't. But she had a lot of questions about needles and options and all that stuff. And I was like, all right, here you go. You're going to hear us talk from a surgeon perspective, but maybe useful.
Yeah, I mean, again, that's why I write my blog, which is what I do for congenital patients. It's written for them. Now, this podcast is not really oriented towards the patient, but a sophisticated patient, or even a non-sophisticated patient, probably can glean something if they really want to be patient and listen to what we have to say. They certainly will understand you and me a little better, and I think that's half the battle with patients. We just want them to understand our approach and kind of who we are as people, because that will affect our relationship.
Yeah, I've had a lot of patients comment on those who have listened to the podcast about just, I mean, even something as small as when we did that Facebook Live thing on shared decision making. People like seeing us in street clothes, like not scrubs, not white coat, not shirt and tie or whatever. So
Absolutely.
well, why don't we jump in? We're supposed to talk about what's new in hand surgery, and it's been really fun doing this for JBJS the last 3 years. By the time this episode drops, I believe this article is being published in print around mid-March. It's already available online. We'll put it in the show notes so that everybody can check it out. But we'll do this probably in 2, maybe 3 parts, depending on kind of how it goes. But my last year doing it for JBJS, it's been a lot of fun. It's forced me in a good way to really scour the literature, and I've learned a lot every year. And I hope that I can find a way to stay this disciplined. But it's hard because you don't always cover to cover read journals anymore.
First of all, it's an honor, and you've done an
Hmm.
amazing job with it. And so
Absolutely an honor.
Yeah, congratulations. I've done something similar again in the congenital world where I look at 6 journals and look for congenital articles, and we award a Paul Mansky Award each year. Myself and Ann Van Heest and Michelle James are the judge and jury here, and it's really been a fun process. But it makes you own the literature, which is absolutely helpful. But like everything, it's one more endeavor, but it's a worthwhile one.
Yeah, so I mean, reading the literature cover to cover is, I mean, it makes you so much better. And this actually came up. The first study we're going to talk about today is one that came up when I was talking to a medical student in clinic yesterday.
Is this did you start this article by talking about sports injuries of the wrist or fractures? How'd you start the article? Let's frame it for the audience.
I started it by order of common conditions treated by practicing hand surgeons, practicing orthopedic surgeons,
Trigger
and plastic
fingers?
surgeons, such
Trigger finger.
as carpal tunnel syndrome.
How
So,
did I know?
and then we went to cubital tunnel syndrome. And then we went to distal radius fractures and peripheral nerve, and I'm still looking for the congenital section. It must have been cut by Mark Swankowski at some
Oh no.
point.
Oh no. So predictable.
Dr. Swankowski had nothing to do with my omission of congenital topics from the literature. I just couldn't do it justice. I just am not that smart, you know. So,
Uh, Wise move. Wise move. All right. Sorry to interrupt you. Jump
oh,
back.
it's okay. So our student was asking. We were talking about the treatment options for carpal tunnel syndrome, and we were talking about the role of steroid injections potentially. And one article that really gave me pause that was one that was published in Hand last year from David Green, obviously the namesake of Green's operative hand surgery. And Dr. Green, apparently, I had no idea, but in reading this article, prior to every carpal tunnel release for a certain period of time, he would have his fellows put a needle to simulate a carpal tunnel injection. And then they would do the carpal tunnel release and see where the needle was. And this was remarkable to me and terrifying, to be honest with you, because and they didn't use ultrasound guidance. It was purely based on our standard clinical landmarks. And of the 756 simulated injections, only 76% were correctly placed. I would have thought we could have done better than that, and I'm not saying I could do any better than what the folks in San Antonio did. The carpal tunnel was missed 118 times, so 16%. And the scariest part is that in 9% of cases, the needle was in the median nerve.
This whole topic of our ability to do in the office what we think we are doing is super interesting. And so I actually had IRB approval. And again, like you said earlier in this podcast, if someone wants to take this and run with it, please do. But I had IRB approval to essentially use an arthrogram every time I did a wrist injection. Because I'm really curious about the role of steroid injections with wrist pathology. Is it temporary improvement? Is it a chance for a cure? And I don't mean to take this in a different direction, but it'll circle
Mhm.
back. And basically, it's just too challenging to get that done. But it's a really interesting study because we do not know what steroids do for wrist pathology. And then circling back to carpal tunnel, I'd be interested to hear how you do it. I think about carpal tunnel injections as the least painful and in some ways the most straightforward injection I do, because I think you get tactile feedback when the needle passes through the transverse carpal ligament. And I really talk to patients in advance about that sensation of electrical feeling shooting to their fingers when I'm placing the needle. But this feels real to me. This feels accurate to me. What do you think?
Yeah, I mean, a couple interesting points. Back to your wrist injection study. I remember when the what was the name of the hyaluronic acid? Synvisc, I think it was. Back in when they were looking at doing randomized trials of Synvisc into the thumb CMC joint. Um, HSS, special surgery, where I did my residency, was one of the sites, and Bob Hotchkiss was the hand surgeon who was involved in that study. And I remember very vividly him telling me in the office how ridiculous it was that the manufacturers didn't believe that he could get into the joint reliably every time without image guidance. So that to the point where he went and did a study where he injected and then they somehow assessed, whether he was in the joint. He's like, I got it 100% of the time. And I'm like, okay, that's great. Like you're Bob Hotchkiss, like but I don't know if, 100% of the time is occurring, across the country. So I thought it was a reasonable request the manufacturer of the drug and whoever was conducting the study.
Does this feel accurate to you? I mean, first of all, how often do you do a carpal tunnel injection? I mean, if you
You know,
give, yeah.
I don't do it that often. I'll be honest with you, and I think that the literature would support that. But to be honest, our perspective as surgeons biases our interpretation of the literature. And I remember in the Stern's classic articles folder, there is rheumatology based literature that demonstrates that injections have long term effectiveness. But then when we did, firsthand last month with Bob Zavo and with Peter Stern, their interpretation of the literature and the multiple meta analyses that have been done is that corticosteroid injections in most patients don't have a role in the treatment algorithm relative to surgery because the long term effectiveness of that steroid injection is questionable. And I'd be interested to see what your use of steroids is. I probably will do a steroid injection in a patient with a diagnostic dilemma who doesn't fit the normal illness script. And I will also consider it in a patient who has a temporary inflammatory state, such as pregnancy or postpartum.
Oh, I totally agree. I totally agree. It can be a useful diagnostic tool, especially when I use the CTS6, not necessarily officially, but at least I can consider it. And when something doesn't add up, nerve studies, CTS6, complaints, it's a really useful for me diagnostic tool that offers a help of improvement. I don't remember the article, but probably 5 or 6 years ago, there was an article in the rheumatology literature touting the effectiveness of carpal tunnel injections, and it was picked up by the New York Times. And so Dr. Governor and I spent a fair amount of time, and this was the royal we, and I was spending a fair amount of time understanding the literature around injections. And as you just said, the literature is not, so at least our literature is not supportive of a long-term answer. And so we wrote a letter to the editor for the New York Times and quoted about a 1 out of 9 improvement 1 year later after a steroid injection. And you probably don't know about that in the New York Times because it was never published. But once again, it was an interesting learning experience.
Or I thought you were about to, casually drop your other, publication in places where I will never publish. Just like, did you publish in New England Journal and mentioned it casually, a few episodes ago?
Yeah, yeah, I'm sure you've read it. I'm sure you've
Yeah,
read it.
exactly, exactly. I think there are like 5 places where I want to publish. And I had this dream when I was a resident. I was like, I want to publish in New England Journal. I want to publish in JAMA. I want to publish in the New York Times and the New Yorker and the Atlantic. And I don't see any of those ever coming true,
So for
given
all
given my current research focus and also lack of non-scientific writing talent.
for all of you aspiring academicians, the first requirement is to have a dream when
Exactly.
you are a resident about where you're going to publish.
Yeah, I'm such a nerd. Anyway, so would this make you shift towards doing an ultrasound guided injection?
I don't think so. I think it makes me shift in the sense that it reinforces the need to be humble. It reinforces the need to be completely forthright with patients. And the whole thing about 8.6% into the nerve, I think if you have the conversation with the patient, I do believe that patients will give you feedback if you are too close to the nerve. I strongly believe that. And so that to me it encourages me to both stay ulnar and listen to the patient.
So you mentioned the tactile feedback of entering into the transverse carpal ligament. When I do my own injection, it's proximal to the wrist crease. So I kind of feel myself more popping through the volar interbrachial fascia, as opposed to the formal transverse carpal ligament. And I do stay ulnar for that reason. And anybody who does a carpal tunnel release or even has to extend across the wrist crease in revision cases will know that that nerve sits right underneath the skin at the level of the wrist crease. And as long as you are ulnar to the, say the midpoint of the wrist crease or the palmaris longus, if the patient has one, you should be fine. And you shouldn't need to go very deep. And you obviously don't want to be in the tendons. And I remember in Dr. McKinnon's original nerve book that she had with Dr. Dellin, um, there is just this picture of an 18 gauge needle into the median nerve that just haunts me. So I'm always thinking of that when I do the injection.
I think that's fair. I do my injection the same way. So if there is a palmaris, I'm ulnar to it. I'm aiming about 45 degrees distal, not quite 45 degrees radial, which is one of the descriptions of how it should be done. but a little bit in a radial direction. And I use a 25 gauge needle. And I really do think, especially in those patients with a thickened transverse carpal ligament, if you're aiming distally, you will feel that ligament. You want to go just slightly through it. And if there's any type of electrical sensation distally, I don't use a water soluble steroid. And some have recommended that if there's a chance you're going to inject into a nerve, you should be using a water soluble steroid. But again, I think, knock on wood, I've not had any long-term issues. And I think the key is just being responsive to the patient's verbalization if there's any concern.
How many injections will you offer?
For unless there's extenuating circumstances, a single injection. This is not, for triggers, it's two, maybe three. For CMC, I'll do them however long the patients want, every 3 to 4 months. For carpal tunnel, it's typically one, unless there are really extenuating circumstances. Is that the same for you?
Yeah, and I'll be honest. I mean, I think, we're surgeons, and that's a bias that we have to face. So we have a lower threshold to offer surgery because we know what we do and we know how we do it. And we typically have a sense of, the risk benefit profile of that surgery. And the calculus shifts for me with Willant. So, for the infirm patient or even the patient who is pregnant, it's not like they have to have any general anesthesia or any sedation. So I think that does change the equation a bit.
Could not agree more. It makes it just, it dials down I don't know, it just dials everything down a notch. So I totally agree with that perception.
You can even call it a procedure as opposed to a surgery. And even that perception, I think, matters to patients. And that's a whole different uh, behavioral argument. Well, speaking of, the next article in the carpal tunnel section was talking about sleep. And I found this to be a very interesting article, in terms of how often patients had improvement in their sleep after carpal tunnel release. And this study was published in Hand again in 2020. And 39 patients, everybody had relief in their sleep at 2-week follow up. And about half of the people had sleep improvement within 24 hours of surgery. Does that match your impression? I mean, people love you when they can sleep better.
So there is no doubt that the primary indication, sorry to say this because I know you think bigger than I do, the primary indication for carpal tunnel release is a lack of sleep. It's what patients hate. They are less tolerant of a lack of sleep than thenar atrophy. And it is a game changer. And I tell patients, when they truly wake up several times a night, they either have to sit up or they shake out their hand, they may go run under hot water, whatever they do, those are the patients that my eyes light up because I know I can help them. And what I tell them is a little different than this, but pretty similar, is you will sleep better tonight. You will have some surgical discomfort, but you will sleep better tonight. And honestly, I'm not sure patients get past the sleep improvement to assess other factors that led to surgery. If their sleep is improved, they're happy.
Yeah, and I think that was that matches kind of what I've started to tell people too. I'm not as ambitious as you in telling them they're going to sleep better that night. Probably should, but I'll say you're going to be sleeping better within the first week or so after surgery. And a lot of times, I've started to ask this question more after reading this study and writing this review article, and it kind of matches. I think it's fantastic. Now, obviously, patients who have other reasons why they're not sleeping well, like cubital tunnel syndrome or sleep apnea or something else, or their kids waking them up, that's not going to change. But at least the carpal tunnel type reason for not sleeping, I agree with this article. I think it's great.
Yeah, the next article you mentioned was, I think it was the next one, was about therapy. And that was honestly just really surprising to me. It's been my perception that we don't cast carpal tunnel releases anymore and we don't send people to therapy. But clearly I'm wrong because about 1 out of 5 patients is sent to therapy.
Yeah.
How do you think about that?
Well, I mean, so the study that we're talking about is one that was done using an administrative database, and that was from Rob Kamal's group at Stanford. And so administrative database, those aren't built for research, but it does, it's very generalizable because it reflects what's actually being done out there. And almost 1 out of 5 patients was getting formal hand therapy after a carpal tunnel release, and they found that added about $400 to the total cost of care. And then, in terms of 5 to 6 visits of therapy after surgery. That just doesn't match my practice, to be honest with you. And I think maybe that's because you and the other faculty at WashU taught me differently. But I would say, it's one of the bigger reasons if I do ever send somebody is for kind of the scar tenderness that tends to occur. Just some extra tips and tricks after I've already tried to counsel them myself and our therapist in the clinic about scar massage and all that kind of stuff. I mean, how often are you sending patients for therapy?
Super rarely, less than 5%, probably less than 3%. And it does end up with for the patient with significant pillar pain, maybe the patient that would do with the silicone padding for a glove to get back to work, something like that. So just not something I do. I have a lot of patients ask about it, and I have to work a little harder to not send them to therapy. But
I'd
it's
say having our therapy, and we have a great setup, typically, pre-pandemic for sure. But I've been fortunate enough that the good folks at Athletico have been great about being in my clinic in South County in one of our, outpatient locations. And it's so helpful to have a therapist there, because you can avoid a formal therapy visit, for something like this because you have somebody in the office who can spend a little more time going through some of the basic stuff. Um, and I think it's really uncommon to have to send somebody for that. You mentioned one thing which came up in firsthand last month, and pillar pain. Is pillar pain? What is pillar pain, and is it different from scar tenderness? Because even godfathers of hand surgery like Bob Zabo and Peter Stern couldn't really give me a good answer on what pillar pain is.
Well, that's a fair question. I think that for me, scar pain is very superficial. Pillar pain implies a deeper discomfort, and whether that's because of a slight reconfiguration of the carpus, whether it's because of division of the soft tissues with an open carpal tunnel release, and perhaps less of that trauma with an endoscopic release for those who favor that approach, I'm not sure. But I certainly think both can exist, but they can also exist in isolation. And it's that's why we tell people, that's why I generally tell people that you may be frustrated with this surgery for up to 4 months while the soft tissues heal, but eventually even that discomfort will go away. And that's about pillar pain to me.
Yeah, I've noticed anecdotally, and probably should at some if somebody wants to do this, go ahead. We're giving out free a lot of ideas today. When you do an open carpal tunnel release, I'd say probably 1 out of 5 patients has you know, a large amount of coverage of the transverse carpal ligament by the ulnar extent of the thenar musculature. And in surgery, at least the way that I was taught, particularly by Dr. Gelberman, it was to sweep those thenars away with the belly of the blade so as to expose the transverse carpal ligament proper. And not all patients have those thenars covering the transverse carpal ligament. And while I mean, maybe I'm wrong. I don't think my patients have a lot of pillar pain. There is some scar tenderness. I can see that as an absolute reason why you would have aching in your thenars after an otherwise, technically well done carpal tunnel release, is that manipulation of the muscle. And perhaps if you were, instead of brushing those to the side to the radial direction, if you just were to cut through them, which I think some people do, that probably would hurt a fair bit. And it's complete conjecture, and not based in any sort of scientific reasoning. I just wanted to put that out there.
I think it's a fair comment, and that's why all of us prefer to divide the transverse carpal ligament as far ulnarly as possible. Of course, being aware of the location of Guillains Canal, you minimize the chance of having to deal with that muscle.
Yeah, and so also one question I wanted to ask you about carpal tunnel release, which brings us to the next article, is what do you tell people in terms of return to work and how long it'll take to get back to work? Because there was the next article we talked about in there was from the group up at Brown, and they randomized people to having therapy, to not having or to not having therapy, or doing therapy at like day 10 after surgery. And honestly, I think that the most interesting finding to me was just their return to work time, which, for all of the groups hovered between 17 days and 22 days. Does that kind of match what you've seen in your practice and perhaps in the literature?
Yeah, I think part of this, and I have a high work comp population in my adult patients, and part of it is about laying out expectations, understanding that there will be patients who both exceed your expectations and don't. And so I tell my work comp patients, no matter what their occupation is, that they will be back to work full duty at 4 weeks. And almost always I accomplish that goal, not always. And for patients that are not work comp who may have a desk job, I do surgery on Wednesday. I'm happy for them to go back to work on Monday. totally fine as long, and it's just about the comfort level. I will let them do what they are comfortable doing. And some patients are very motivated, some patients are not. Some patients have a higher sensitivity to discomfort. It's so variable that I've learned that I don't want to be too prescriptive in what I say. But for work comp patients, for me, the expectation needs back to work full duty by 1 month.
Yeah, I think I try to set that expectation too. I don't know if I'm as good as you of being firm about it and making sure to get people back. I think that some people who have heavier lifting and manual labor have a harder time with the 1 month thing, but we try as much as we can to get them back there.
Absolutely. Do we have time to cover cubital tunnel and then not talk about nerve next episode?
I think we do. We can skip over nerve for the next one. The cubital tunnel literature, I think there weren't a ton of articles that I pulled out that I found very interesting. There was one study that looked at patient satisfaction after an in situ ulnar nerve decompression, and in this study, 83% of people after in situ ulnar nerve decompression were pleased. Does that kind of match, your impression of your practice?
It does match my impression, although I think as we've discussed, I have narrowed my indications a little bit, but it does match my practice. What about you?
Pretty much the same. But also, I have pretty narrow indications for an ulnar nerve decompression too. And I thought what was interesting in this study is of the people who were not satisfied after surgery, they all had preoperative ulnar intrinsic weakness, which says to me perhaps, the indications for this surgery should be reconsidered and maybe tightened a bit. And I know there are a lot of diehard in situ ulnar nerve decompression people, and feel like an ulnar nerve should not routinely be transposed. But if you do have 1 out of 5 people that is not satisfied after this surgery, that is something to consider.
In the original neurosurgery literature, which looked at decompression versus transposition, the results, as I recall, were pretty equivalent between the two procedures, even with intrinsic findings. That's never been my practice because part of this for me, in Ryan Calvi's article, which we should touch on, is really important in that regard. But part of this for me is doing the surgery so that I know I've done all I can for the patient. And if tension is a component, decompression does not address tension. And if I decompress a patient with ulnar intrinsic weakness, then I'm worried I haven't done everything I can do for the patient. And if they don't get better, the patient wonders the same thing. And so for those patients, I almost always transpose.
And if they have to have a revision, another one of Ryan's papers has demonstrated that revisions, while they get better, it's not as good as if you perhaps did the transposition right off the bat. That should be counterbalanced by the fact that a transposition has more morbidity, and it's a longer recovery, and there's a higher risk of complications, and that certainly, should not be ignored. I think you wrote the original paper on one of the original papers on decompression revision rates with Dr. Mansky, and you guys had about 7%, right?
That's right. That's right.
Yeah.
And that was based on his work in the 90s and early aughts.
Yeah. And then, more recently, Ryan has shown a revision rate that's higher, closer to 20%. And, probably there is, maybe that matches a little bit with this 1 out of 5, not satisfied, that was found in this other study. But I do think that the indications probably should be tightened a bit. But I, recognize that this is it's a controversial area for sure.
Absolutely. And it would take a really well designed, large enrollment to answer this question definitively. And it's tough. It's tough to design a study like that. So ultimately, we're probably going to have to deal with either database studies or incremental improvement in our understanding.
So, there were no great supercharged studies for cubital tunnel this year, so we'll spare you for that. But there is a teaser for the next episode. If we do get back to nerve, there are a few interesting supercharged studies in the setting of trauma that might be good to talk about. But I know that you probably want to get to something like a fracture or sportsy or something like that, because I've pulled us way into the nerve realm deep today.
I say this with great hesitation, but I do enjoy the nerve conversation because I always learn something. So I'm not against it completely.
Can I ask you one thing before we go about, in a prior podcast, I think you mentioned that in a work comp population, you will pretty almost always do a transposition. Is that correct?
It is interesting. It's been an evolution. When I first, 2003, 4, 5, would ask for approval for a decompression from the work comp carriers, they would say no. And then they began to understand that it's a quicker recovery and there's clear benefits to it. And so now if I don't offer a decompression, there are questions, why are you not just decompressing this? I tend to have, again, the goal, especially with work comp, is one surgery and one surgery only. And so while I will occasionally do a decompression in what I would call a perfect patient, where the nerve is stable, where the nerve is reactive at the tunnel, but there are no signs of atrophy, 2 points fine. All those kind of things are good, but the patient remains symptomatic and they're slowing. The perfect patient can get the decompression, but if it's anything other than a perfect patient, I transpose them.
And is that in a work comp population? Is that routinely subcutaneous or submuscular?
Depends a little bit on the patient. If I'm a little concerned about patients' interest in a full recovery and interest in a speedy full recovery, I will go ahead and do the submuscular, just because, again, I want to know there's nothing else I can do for this patient at that first surgery, after that first surgery.
Fair enough.
Does that resonate?
Yeah, I just, I remember you mentioning it in a prior podcast, and I just wanted to slip in some more nerve talk into the episode. So,
Perfect.
well, thanks
Listen,
a lot. Thanks for entertaining all of this, and I think there's a lot more to talk about, and look forward to us talking about what's new in hand surgery from the last year.
I look forward to talking about that. And you had sent me an article which I don't want to lose sight of, from HBR, talking about how to stop overthinking, and we do need to hit on that. So our cup is overrunning with potential future episodes. So as always, this was fun. Good luck on your ride today.
Oh, thanks, and enjoy your wonderful day.
Awesome. Thank you.